The presentation is really around the health economic value associated with treating HIV. And just wanted to throw you in at the deep end to start with, just a small amount of theory. So in relation to health economics, what we're really trying to achieve is maximizing value for money. In particular, seek the greatest amount of health benefit for the least cost. And that'll lead us to a concept that we'll talk a little more in subsequent slides, but that leads us to the notion of cost effectiveness, which is really focused on measuring the explicit inputs that we use and outcomes that we'll use in our evaluations. And the little graphic in the bottom right-hand corner there is really the fundamental concept of what we're trying to do here is to measure the relationship between the costs of doing something and then the benefits that we expect to accrue as a consequence of doing that. This next graph is a conceptual plot designed to illustrate how in any chronic condition, whether it's HIV, hepatitis C, diabetes, COPD, we get this notion that costs will increase over time as a function of the chronic condition progressing. And here we're looking at an index of 100, and so over time costs will increase. The fundamental problem that we have in healthcare is that if we're going to invest in managing a chronic condition such as HIV, invariably there's some upfront investment cost that's required. And what we obviously see very immediately is the magnitude of that investment cost. And what's more challenging to ascertain is both the magnitude of the health benefit that we're buying for that investment, as well as the timing. And I think in cash-constrained societies across the globe, that's the struggle, is that when and what's the magnitude of the health benefit that we're buying by investing in either new technologies or implementing new methods of delivering healthcare in today's money. What it also does is it focuses attention on costs, and I think that's quite natural. I'm just going to show you a couple of slides taking slightly different perspectives, both UK, but these kinds of studies have been done across countries. Generally, what this slide is showing is that from 1997 in the UK, the cost of treating HIV was around 164 million, made up of both antiviral therapy as well as hospital and outpatient costs. By 2008, that had increased to around 700 million and projected to cost about $1 billion by 2013, which is about right. Much of that cost increase is driven by more patients in care. In 97, there was around 18,000 patients in care. By 2006, it had increased to around 50,000, with around 80,000 by today's standards. So much of the cost being driven by more patients being treated in the healthcare system. Another way of looking at costs is to look at, rather than just what does it cost the health system per year, is to look at what does an individual cost over their lifetime as a consequence of their HIV status. And this study estimated that the average cost is around £360,000 over the lifetime of the patient. And you can see on that pie chart there, this area in kind of pink and red illustrates the proportion of that cost that's attributable to antiviral therapy. So it's around 2/3. The point they were making with this study was that you can reduce costs by using more generic therapies, but the real value is obtained if you can prevent HIV infection in the first place. So strategies to minimize the cost of therapies as well as prevent HIV infection occurring in the first place would be sensible strategies, and indeed they are. I think that from an economist's perspective, the problem with looking at just the costs is it ignores the health benefits. There is tremendous costs associated with identifying and managing patients with HIV, but what are we buying for that money? And what I've put together here is just a conceptual outline using contemporary epidemiological data describing disease progression in HIV to just characterize what we'd expect to see in terms of life expectancy or gains in life expectancy and quality-adjusted life expectancy as a consequence of 3 hypothetical patients here called John, Peter, and Paul. And what we've done is just estimated if we were to start treatment, for these were treatment-naive patients aged 43, John maintains virologic suppression with first treatment and is compliant throughout. We would expect from the age of 43 about a further 30 years of life expectancy. Peter is cycling through treatments, and maybe there's a period of intermittent therapy, but generally speaking, approaches a similar level of life expectancy. In contrast, Paul fails to achieve and maintain virologic suppression, either because they're unidentified or non-compliant, but whatever the reason. But the point I'm trying to illustrate here is that the magnitude of difference between being treated and being not treated in terms of life expectancy is extraordinary. And it's that money that's being bought with that investment. What's also presented there is the quality-adjusted life expectancy. So in addition to wanting to extend our life, we also want to maintain a good quality of life. And the quality-adjusted life year is a way of doing that. And we can see that when we adjust for quality of life as well, again, there are substantial differences. There's about a gain of about 10 QALYs between essentially treating and non-treating. At the risk of turning this into a tutorial in health economics, I wanted to just pause for a moment to just describe exactly what a QALY is, because it's a very simple measure, but people band around these terms, I think, to try to make us appear more intelligent than we actually are. But it's a very simple concept. And the QALY is essentially utilizing a measure of quality of life on a scale of 1 to 0, 1 representing perfect health and 0 representing death. And what we're able to do with a QALY then is to count up the number of years lived, but then to weight that those years lived by your quality of life. And here we're looking at 2 hypothetical scenarios where, as patients experience complications, their quality of life decreases. So all we're doing is capturing 2 components. One is the amount of life lived, and then we're adjusting it for quality of life. And that's all there is to a quality-adjusted life year. If we had 2 interventions here, intervention A and intervention B here, the difference between these 2 lines represents the QALYs gained associated with these 2 interventions, whether they're drugs or whether they're ways in which we deliver healthcare. So we've talked so far about costs and benefits, and that leads us to the fundamental concept of cost effectiveness and the incremental cost effectiveness ratio, which seeks to explore the relationship between the additional costs of a health intervention and the additional health benefits that it brings. And we do that by calculating the total costs of our new technology, A versus B, and we divide that by the health benefits associated with A and B. And those health benefits are typically calculated over the lifetime of a patient. And the reason why we focus on the quality adjusted life year is because essentially 2 things. One is it enables us to measure the health benefit across lots of disease areas. If we're able to use the metric that's common to HIV as it is to oncology, as it is to fertility treatment, then we can compare at a population level what our nation is getting in response to investment in healthcare. The other thing is we can attach a value to it, and that's probably from this the perspective of this talk, the most important. In the UK, for instance, we attach a value of £20,000. So we're prepared to spend £20,000 to gain 1 additional quality-adjusted life year. So we would deem that to be good value for money. And from the example with John, Peter, and Paul, for instance, between Paul and Peter, there was a gain of about 10 QALYs. So in the UK, for instance, we'd be prepared to spend about £200,000 to realise a gain of 10 QALYs. So there are big numbers involved in treating HIV, but there are corresponding big gains in health, and I think that's the important relationship to remember. So just to move on then to finally move on to HIV and to talk about a concrete example, I wanted to try to give away the secrets now of exactly how we do health economic evaluations, initially starting with comparing 2 drugs and how it's typically done. Now, I've picked this paper not because it's a particularly relevant one or particularly good or bad, it's nice and easy to explain. And what we've got on the left-hand side here is a flow diagram of, I'm sure you'll recognize, CD4 cell counts. And what we would typically do is construct a health economic model describing patients moving through CD4 cell count states. They can stay in states or they can move around them, and ultimately they can die. Now, the key to the evaluation really is in this table. So here we can see the CD4 cell count range, and associated with each of these ranges is a mortality rate. You can see lower CD4 count is associated with a higher mortality rate. Quality of life, as your CD4 count decreases, it starts from a utility of 0.9, so close to 1, and comes down to 0.78. So the lower your CD4 cell count, the poorer your quality of life. Conversely, this is a US study. These are non-therapy related 3-monthly costs associated with managing patients. And so the health economic value associated with treating an HIV is really around keeping patients in the highest CD4 cell count with the lowest mortality rate, the best quality of life, and the cheapest costs. It's kind of common sense. But that's essentially what drives a health economic evaluation. This particular study by Brogan and colleagues looked at darunavir versus lopinavir and compared it over a lifetime with a rescue therapy, running it through a model as shown in the previous slide. The difference in efficacy, as I recall, was around 70% versus 60% achieving virologic suppression, that kind of order of magnitude. And then so the difference in patients achieving suppression drove an overall difference in cost. So around $600,000, but slightly more cost for darunavir, but with slightly greater gains in quality adjusted life years. So you can see here the difference around $11,000 buying essentially half a QALY. I guess the first point to make here is in terms of the absolute magnitude of health benefit and costs compared to the hypothetical example with John, Peter and Paul, where you saw huge gains. When we start to compare technologies, what we're often looking at is relatively modest differences in efficacy driving relatively modest differences in outcomes. One of the key ways to present this analysis is on what's called a cost effectiveness plane, where we can present on this y-axis the incremental costs and on the x-axis the incremental health benefits. And in the US, the WTP stands for willingness to pay. So in the US, they're willing to pay around $100,000 for each additional quality adjusted life year gained. And so the blue dot here, which is just the 11,000 on the y-axis and the 0.493 on the x-axis, that's that point there. Because it falls below that line, we would deem that to be cost effective and producing an incremental cost effectiveness ratio of around $23,000, so highly cost effective. So that's essentially how we calculate value in associated with new technologies. This slide shows the results from a meta-analysis looking at virologic suppression as a function of year of study, starting in around 95 up to 2010. And as I'm sure you're all well aware, the efficacy of new treatments has been increasing here on average around 43% in 95 up to around 78% in 2010. But not only has virologic suppression been increasing, but the standard deviation around these studies has been decreasing as well. So, a converging level of increasing efficacy. As well, this graph on the right-hand side shows the treatment discontinuation, predominantly as a function of either adverse events or patient choice, and that's been decreasing as well over time. The point I wanted to make with this slide is that when we continue to do health economic evaluations of new regimens in HIV, what we'll be seeing is increasingly marginal differences between these new technologies. So whether it's fixed dose combinations compared to multi-drug regimens, we'll see increasingly narrow differences in terms of health economic costs as well as the benefits accruing, which is in contrast to the gains that can be reduced by identifying patients, linking and retaining them in care. And I'm sure this is a graph that you're familiar with, looking at a US study in which it's estimated around 1.1 million patients living with HIV, around 80% of those aware of their HIV status, but only around 40%, so around half of those aware of their HIV status actually retained in care. And of that 40%, you're down to kind of 20 to 30% who are fully adherent to their therapies. That's of particular relevance because this, again, this is a modeling study from the US looking at different methods of care in terms of the number of future HIV infections over the 20-year period of 2015 to 2035 and the number of AIDS deaths over the same period. And at the top is the current continuum of care. So this is identifying patients through existing screening programs and treating all of those regardless of their CD4 cell count. And it's estimated that there'll be about 1.4 million new HIV infections over that 20-year period, with around 400,000 AIDS deaths associated with that. And then these various scenarios, A, B, C, D, and E, look at, well, A, B, and C are looking at different targeted screening programs. So whether that's screening targeting high-risk individuals, or B is general population screening. The point the authors were making with this study is that what you see then is a reduction in the number of new HIV infections, but not a dramatic reduction. It comes down to about 1.1 million new infections. It's not until you start improving retention in care and then combining all these packages that you start to reduce the number of new HIV infections down at the bottom here, where they implement each of these strategies, reducing the number of infections by around 750,000, and the number of AIDS deaths by about 250,000 as well. So significant gains to be had through retaining patients in care. So the health economic benefits of linkage to care, these numbers, again, reasonably consistent with what I've shown before, but a number of studies estimating that the costs, lifetime costs associated with HIV are in the region of $200,000 to $400,000, with lifetime QALY gains in the region of 4 to 7, slightly less than I presented earlier because these costs and health gains have been discounted. But nevertheless, so, substantial investment, but substantial health gains. It's not really until you start considering secondary HIV, so the consequences of future infections avoided, that the benefits of identifying patients and linking and retaining them in care really become evident. And here we're looking at $300,000 to $500,000 of costs saved per infection avoided. And in the previous slide, we're talking potentially of hundreds of thousands of new HIV infections avoided through screening and retention programs, as well as 5 to 13 quality-adjusted life years saved per infection avoided. So tremendous cost associated with managing those patients currently infected, but tremendous healthcare gains as well, but even bigger gains associated with avoiding future infections. But none of these figures take into consideration things like the impact on lifestyle, relationships, social exclusion, as well as work and income. And so we haven't looked at the effects of HIV in these slides on the kind of broader macroeconomics, gross domestic product, and so on. Obviously, HIV disproportionately affects poorer patients, in particular with their ability to supply labor, so a tremendous impact on that front as well. So to summarize, so improved identification, linkage, and retention can be associated with significant gains in life expectancy and quality-adjusted life expectancy, but also an increase in short-term costs in the short term, and that's the particular issue. One of the things that often gets, I think, misunderstood is if something is cost-effective, it doesn't make it cost-saving. Something might be good value for money, but it's still going to cost additional money. And the problem is that healthcare systems around the world typically operate with a fixed budget. So if you invest more in one area, it's typically at the expense of healthcare spend in another area. But understanding the relationship between what you're investing in and what you're receiving is crucial. Over the longer term, the cost offsets associated with reduced transmission risk significantly impact predicted cost effectiveness. And I guess this is the rub. The more people you treat, the more cost effective it becomes to treat them. Likewise, the more you screen and the more you treat, the more cost effective. And I think that's the converse is true. By embarking on a very expensive screening program and then not treating people or not retaining them is where the most inefficient resource use lies. The efficient allocation of scarce resources requires acknowledgement of all the relevant outcomes. I think if you just look at pharmacy costs, you'll always be disappointed. In the sense, you've got to look at what are you receiving for that investment. And then finally, the economic consequences associated with barriers to care extend well beyond those directly affecting the healthcare system. So the costs and consequences at the moment that I've presented have been related to direct costs to the healthcare system and to the patient themselves. But there's a much broader impact on society as a whole, as well as the economy as a whole. Thank you very much for your time.